is important to talk about asthma probably every month. Okay, it's very important. This is the most one. Okay, it's very costly. Okay, the cost uh, of not treating the patient is more than treating this patient. This is why you really know how to treat this patient, and you have to educate yourself almost every day about this disease, because there are so many treatments. Some of them are useful and some of them are not, but this is why you really have to select the proper medication for your patient population. So all the things that I'm gonna talk, it's in this reference, the Saudi Initiative for Asthma, in the guidelines, and it is by the Saudi Thoracic Society, and the website is given to you here in this slide. So what is asthma? It's a chronic inflammatory disease of the airway that causes airway hyperresponsiveness, mucosal edema, and mucus production. Asthma is a reversible airway disease, and this is why it's very important to treat it, because you can reverse the disease. And if you don't do that, the disease become chronic. Patient will be coughing, they will have infection, and then if they are children or others, they cannot go to school or they cannot go to work. They will have school absenteeism and absence from work, and this is a loss. This is the economy of the country really drops because of if you don't treat asthma patient, because they lose a lot of work days, these patients. So this is why it's very important to know how it's very easy to talk, but actually in practice it is difficult. It's not easy to control these patients. There are so many factors that it is not easy to control. One of them is actually physicians themselves. They don't know how to use the medication. They have done a screening survey for physicians to see how many of them can give the medication properly, the asthma medication properly. Can you estimate what is the percentage of physicians were able to identify the proper treatment for the asthma? Can you guess?
50 to 60%.
Any other guess? Well, it's actually around 20 to 25. So it's very, very sad to hear that. It's not us. It's also North America. So you see that it is very what do I say? You may underestimate people talking to you about asthma because you hear it every day. But it's actually difficult how to treat, asthma, and how to use the proper medication, how to use the equipment, and so on. This is why you have really to educate yourself. When you become a physician, when you are an intern and a general physician or whatever, you really need to educate yourself almost every day. There is almost every day a new tool to treat these patients. So please, try to educate yourself. And I mean, usually when it becomes live presentation, I usually bring all this medication, all this equipment, and I ask the student to try it and to hold it and to look at it and see the color, see how it is used, how it is done, and so on. But unfortunately, because this is distant, I cannot show you. I want you to look at it in the internet and see how it is used, because if you don't educate yourself, it's really very important. I mean, it's easy to write the medication, it's easy to refill all this medication, but if you don't show it properly, the patient will not use it properly. And this is because all the medication will be in the air. So it will not be effective in treating these patients. So it's characterized by chronic airway inflammation, increased airway hyperresponsiveness, leading to wheeze, cough, chest tightness, and dyspnea. We mentioned that it is a reversible disease, and this is what is good about it, because if you don't treat it, it will become irreversible. And once it becomes irreversible, that means there is angiogenesis, there is fibrosis of the airway, so it is really difficult to return it back to its normal function. Patient with asthma may experience symptom-free period alternating with acute exacerbation for hours or minutes. So this is the way it looks, the airway. If this is the normal and this is abnormal, you can see the secretion inside the bronchi, the edema of the airway, epithelium, and also the stenosis or of the airway itself. And that's why you need to, when you treat patients, you have to use all these three elements. You have to reduce the inflammation, because asthma is an inflammatory disease. And the first line of treatment is actually anti-inflammatory. So it's not really as it is used to be taught is a bronchodilator. No, you cannot bronchodilate if you cannot improve the inflammatory process. Because if you bronchodilate, but you don't improve the inflammatory process, the secretion will continue, and the excitation and the irritation will continue, and the bronchospasm will lead to bronchospasm and more secretion and so on, and the obstruction will continue. So the first line of treatment, please, is anti-inflammatory. And that's why when you treat an asthmatic patient, you have to use anti-inflammation all the time. Not only Ventolin, which is the bronchodilator, it has to be accompanied by an anti-inflammatory medication. Around 300 million people have asthma, and expected to be 400 million by 2025. In Saudi Arabia, the incidence increased from 8% in 1986 to 23%. That's a study, to 23% in 1995. So according to where you are located, like for example in Riyadh, the incidence of asthma is around 13%. If you go to the east, is around like 23%. If you go to the southwest, like in Jizan, Najran, and so on, it's around 15, 17%, and so on. So according to which location, it ranges from 8% to 23% in Saudi Arabia. So at least if you say, if this is true, around 5 to 6 million of our population have asthma. So almost from you, if you are 100, for example, at least 4 or 5 of you will have asthma. So I'm sure there are some of you are using asthma medication. So as we mentioned, the cost is really tremendous. It really costs the country. This is like the economy of a single country, just spending it on treatment of asthma. So it's very costly to every country. And this is why we really need to direct this treatment properly, rather than, losing this money in the garbage, like throwing it in the garbage. So it is an inherited disease due to probably chronic exposure to airway allergens. So there are so many triggers, and you could be asked in an OSCE exam, so what are the triggers and so on. I'm sure everybody know about it. So triggers, like if you look around you in the room itself, you will see that if you have carpets, this will accommodate dust. If you have curtains, if you have books, it will accommodate dust and mites and so on. If you have toys, for the children around their room, anything with fur. So any toy with fur will accommodate dust, and it will bring the asthma for the children. So if you have children with asthma, you have to tell them they have to buy toys that they don't have fur, which has a cloth so that you can use, you can wash it. You need to wash these toys at least once a week in a hot water more than 60 degrees, to kill the mites. So the main problem in asthma is really the mites that really be transmitted through the airway. And it's very ugly. I'm sure you know how the mites they look like. They are very ugly, very pathogenic. Once it gets into the airway, it really causes this inflammatory process. A lot of inflammation that it is caused by these mites. So, in your bed, you have a pillow, you have a bed sheet that can accommodate the mites, and this is why we say for the asthma, they have to have a bed that is plastic. Like if you look to the hospital bed in our hospital, you see that the beds are really plastic, and plastic doesn't really allow the mites to accommodate. But if it is from cotton, for example, or from wool, it really accommodates mites. So, but if it is plastic, it's easy to clean, and you can get rid of the mites. The same thing for the pillow. If you have a cotton pillow, it will accommodate mites. And they always advise that you have to change your pillow every 6 to 12 months. So why is that? Because they say 10 to 20% of the weight of the pillow are mites. So you really have to be careful if you are asthmatic, that you may need to change your pillows that frequent because of the mites accommodate in cotton. So you have to buy the asthma pillow, which is actually plastic cover, and then you can put the cotton on top of it. At least the cotton you can change it every week, but the pillow itself you cannot change it every week. So you can just clean the plastic part of it and then put cotton on it. So anything, the cloth itself, if you have a wool during winter time, you have to advise them to actually wear cotton that is heavy and so on, but not really anything that has hair, because it accommodates the dust and the mites and so on. Animals, cats, dogs, birds, anything that have fur, you have to get rid of it. People may say, well, they play with the birds and the cats or whatever when they go out. No, because the air from that area will come to the house and so on. It will carry with it the mites and the fur of these animals, and it will get into the airway. So you just have to get rid of them. That's the main issue here. You have to insist on these families to get rid of any animal that they have in the room or in the house or even around the house. They just have to get rid of them because it's gonna bring it. If you have a cat, for example, in the room, do you know how long the hair of the cat will stay in the in the curtain or in the carpet and so on? Do you know how long? The effect of the hair of the cat, even if you clean it by vacuuming or whatever. Does anybody know?
A couple of months.
2 years. 2 years. So if you get rid of the cat now, you still have some hair there. So the sooner the better to get rid of the cat. So it's really a serious problem for this patient. Don't underestimate it. You just have to insist on this patient to get rid of the animals that they have. And that's the only solution to reduce the number of or the amount of triggers that they have. Smoking is very important. Okay, sometimes they will tell you, well, the father smokes, but he smokes only at work. No, smoke will really attach to your skin. So even if you tell me that he changes his clothes every time he comes before he kisses his child and so on, no, because it is in the skin. So when he kisses a child, it is in his skin. So it's going to stimulate, going to irritate the child. So please, again, it's like getting rid of the animal. You have to get rid of the smoking. Totally. Don't tell me I'm smoking out, in the work and so on or outside. It has to be stopped. That's the main thing. You have to stop it. Since you are living with the child, you have to stop smoking. So that's very important. Again, asthma, urticaria, it's a sign of that this patient may become asthmatic for a long term and so on. So you have to check on that history. Travel, any, what do I say, manufacture around you with dust and fumes, any perfume, it may bring it up. And the way to discover it is to ask, does he cough when there is مثلا عود أو بخور or any smell? So you have to get away from that smell for that child when he's affected. So you would, the mother would know what kind of allergy does he have, so she has to get away from that perfume or bakhur or whatever perfume that she has. Pollen, mold, dust. So there are patients who are sensitive to dry air, and some asthmatic are sensitive to actually humid air. So some patients, they have asthma in Riyadh, but when they go to Jeddah, for example, where it is humidity, they may become less attack. The opposite may happen. They have asthma in Jeddah, but when you come to Riyadh, where is a dry area, they become better. So it's according to what the sensitivity or what the triggering factor for that asthmatic patient. Occupational environment patient, sometimes when they exercise, when they run and so on, they may have asthma, which we call it exercise induced asthma. And the reason is that usually when you walk, your nose will warm the air, but when you run, because it really becomes very fast, so it doesn't have the nose doesn't have a chance to really warm the air, so it becomes cold and it may stimulate the cough reflex and so on. So exercise may cause asthma. Even laughing may cause asthma. Other pollution in the air, you have to check about the environment of the patients. Cold air, sulfur dioxide, beta blockers, aspirin, stress, a household spray, paints, and so on. So how it is, caused? It's mainly due to the allergen itself. It causes IgE stimulation, mast cell degradation, and then once you degrade this mast cell, which is in the acute stage, it produces prostaglandin, and this will cause airway responsiveness, inflammatory process, and also at the same time it produces bradykinin and leukotriene. So we're gonna talk a lot about this leukotriene inflammatory process in asthma. So again, when you have airway hyperresponsiveness, there is bronchospasm, there is mucus secretion, and then there is the obstruction. So this is the three elements of asthma cause in this disease. Then it will cause shortness of breath, tightness, and so on. So we mentioned that there is the immediate, which is due to the mast cell degradation, and there is the late or the allergic response due to the leukotriene from the eosinophil. So the main trigger, really, the pathophysiology is due to the release of interleukin-4, interleukin-13, and interleukin-5. It's very important that you put in your mind these three interleukins, because these are the main pathogenic materials that cause this asthma and the inflammatory process in this patient which cause you can see how severe the bronchoconstriction happens due to this inflammatory process, due to these different interleukins. So it's usually a type 2 in inflammatory process, and there is a non-type 2. So the type 2 is more severe, mainly blood eosinophilia. So if you do CBC, you will find high eosinophil, more than 150. Elevated tissue eosinophil, elevated serum IgE, and this is what we do. Elevated inhaled nitric oxide. So this is a test that we do by an equipment. It may respond to corticosteroid, and also, most usually happens due to the interleukin, as we mentioned, 4, 5, and 13. Whereas a non-type 2 is mainly neutrophils that you will see, and usually these patients are obese and it may not respond to steroid. So here it shows how interleukins cause this inflammatory process, like interleukin 2 through Th2 cell differentiation, and it causes eosinophil recruitment and trafficking, B cell switching and IgE production, mast cell activation and trafficking to tissue, fibrosis of the airway, and airway hyperresponsiveness. Again, interleukin 5 will cause eosinophil differentiation and survival, so it increases the eosinophil. So sometimes you really want to target the interleukin 5 in some patients, and in some you want only to target the interleukin 13, and it's according to how the symptomatology, and sometimes you do lavage and to see how much of the eosinophil are there, and so on. I don't want to go, but we mentioned that the main thing is I wanted to keep it in my IL-4, IL-5, and IL-13. All of this, it really goes into, the cells, the lung, and all blood cells will be affected. Eventually, it's airway hyperresponsiveness, airway obstruction, inflammation. These are the three components that will happen in asthma. If you don't treat it, there will be subclinical fibrosis, and so this disease may become irreversible. So if you don't reverse it early, then it will become irreversible. Clinical manifestation, it could be shortness of breath, chest tightness, breathlessness, cough. Cough alone, cough more than 2 weeks in any of you, okay, it is caused by hyperresponsive airways, and you may have asthma. So if you have a flu-like illness, usually the flu should really improve within 2 weeks. But if you continue to cough after that, you have hyperresponsive airway disease, and you may need anti-asthmatic medication. So don't suffer. Don't continue to suffer if you have cough more than 2 weeks. You have hyperresponsive airway disease, and you need bronchodilator and anti-inflammatory. So they may have diaphoresis, tachycardia, widened pulse pressure, especially those who have, severe bronchospasms, hypoxemia, and probably central cyanosis, and so on. Very important, again, asthma is a diagnosis of exclusion. So you cannot say that this patient has asthma until you really work out in your brain and ask the question to rule out all these asthma mimicker or, the differential diagnosis. So you have to ask, is this cough or sputum production, is it due to chronic bronchitis, which means that you have a production of sputum for 2 months in 2 consecutive years, so if you have that history, you have a chronic bronchitis. So this is different. This is not asthma. You may have allergic rhinitis and sinusitis, you have to check that it's mainly from the nose and not really down in the airway. Primary ciliary dyskinesia is again a genetic defect of the cilia of the airway, gastroesophageal reflux, congestive heart failure, vocal cord dysfunction. You have to rule all this out. Bronchomalacia, tracheomalacia, tracheobronchomalacia. You have You have to ask them about the voice of the patient, about the type of cough. Is it croupy? Is it dry? Is it productive? And so on. Aspiration pneumonia. Foreign body aspiration, you have to ask if they ever had aspirated foreign body. And then lastly, the cystic fibrosis, the conditions that we talked about, you have to ask about all this question. So if you have, let's say, an OSCE exam telling you that you have, for example, a 4 years old with cough and sputum production, you have to tell all these differential diagnoses. And then you have to talk about the triggers of asthma and so on. So there are triggers that are very important that you have to know, and you may lose marks if you don't mention it, which is mainly the smoking, the eczema, and the rest. You could have maybe 20 triggers you mention, and it may only be counted like 2 or 3 triggers. That is important, but very important to mention about the smoking and the eczema in the patient. It really carries a big weight in the question. So asthma, you have to ask a history about shortness of breath. Is it seasonal? It should be 3 attacks per season. Coughing more than 2 weeks, as I mentioned, and usually during sleep, not necessarily related to upper respiratory tract infection. Wheezing, atopy, we mentioned, family history of atopy. Maybe you can do pulmonary function test, especially above 6 years of age. Chest X-ray may show hyperinflation, and to rule out, of course, other pulmonary congenital disease. And then the skin testing or the IG level in the blood. So this is the way. And then, of course, it could be also by trying the treatment. If you give them Ventolin to see if they improve, that means, especially below 5 years, if we cannot do pulmonary function, you can try the medication. Really, it is not harmful. And if they tell you the patient improves, that means the patient has hyperresponsive airway disease and they need the treatment. There are many times below 5 years. It could be transient, and usually within the first 3 years of life, associated with prematurity and probably parental smoking, or it could be early onset, usually about beyond the age of 6 years, and usually associated with viral illness, and could be associated with atopy in the history. Late onset usually persist into childhood, and usually they have a history of atopy. What is, the accurate diagnosis is crucial to prevent inappropriate management. Rather than giving them the medication, you need to see maybe they have another disease that they need to be treated differently, or probably to prevent unnecessary treatment. Patient education, an action plan, and prevention is a major part in asthma treatment. So you really have to educate parents, to tell them how do they act when they have increasing cough. Just increasing cough, that means the patient is really having an asthma exacerbation. So they have to abort it immediately, otherwise it will progress. And some patients may die from asthma obstruction. So please don't underestimate asthma. It may kill. And I have a lot of friends, they underestimated the asthma and their children died. So please don't underestimate, the problem of asthma. You really need to treat it because, again, it is a reversible disease. But if you don't, it becomes very, very bad. Management, our ultimate goal is to maintain normal pulmonary function and normal, activity. If the patient, let's say, he say every time he goes to exercise in school, he would stop and cough and cannot breathe and so on. So you really need to tell them, let's say, to take anti-asthmatic before they go to exercise, or in the middle if they develop, symptoms, or after exercise. So they have to sit and give themselves as a medication, and then they can continue the exercise. They can be athletes, they can run in marathon and so on, but they have to treat themselves properly. So don't underestimate the what do I say, the strength and the motivation of these patients. Don't put them at home. Don't isolate them from the society. They have to be normal children. They have to live like normal. But you tell them you have to take your medication. If you have exercise asthma, you take it before you go to exercise. And if you develop symptom, even with an exercise, he has to stop and give himself the medication. And they can live normally. So please, you have to really to diagnose asthma properly and give the proper medication. We need to, of course, minimize the emergency visits. As we mentioned, the cost of emergency visit, school absenteeism, and the treatment and the admission for this patient is very costly compared to the, offering proper treatment to this patient. Of course, also to improve quality of life and reduce the risk of adverse outcome and reduce mortality. طيب. I want to come, there are scoring for the severity of asthma and so on, but I want to come to the medication. I want you to really sense how does it look, this medication. So below 4 years, we use this air chamber, we call it. So we put the inhaler at the end. This is the mask, this is the nasal part, and this is the around the mouth. So you put the mask around the nose and the mouth. Okay, there is a special technique. Unfortunately, I cannot tell you how, but you have to shake the puffer before you put it in, and then you put it in the distal end. You have to tighten that mask on the child, and then press on the puffer. And below 5 years, you have to count 1 to 10 after each puff. So if you give 2 puffs, you have to count up to 20. And you shouldn't really remove the mask immediately. No, you have to keep the mask on the face and count up to 20. Or if he is above 5 years, you tell him to breathe very slowly and deeply, at least 5 breaths per each puff. So that's very important. So the way to give it is to give 2 puffs every 4 hours if he has an attack, and to reduce it once the cough attacks are reduced and so on. The other one, which is the blue one, is usually given above 4 years, and this is the mouthpiece. The distal end is the one that you are gonna put the puff. But this is the mouthpiece here. And the problem with that is that you really need coordination in this air chamber, because he has to breathe in, and when he breathes out, he has to breathe out from his nose and not to breathe it out into the mouthpiece itself, because otherwise, it is not going to benefit him. So that's why it's really given to patients above 4, sometimes even up to 8 years. They don't know how to use this air chamber. So you look to the color. There are so many colors in asthma treatment. This is the most used one. It's the inhaled steroid. It's the fluticasone. And it has different grades of color. Like the orange one is only the inhaled steroid, the fluticasone. And it's given, of course, through air chamber. And again, this is the same thing. So these are the different color grades for the inhaled steroid. This one, the very pale orange one, it has 50 microgram per puff. The grade after it is 125 microgram per puff. And then the other one is the 250 microgram per puff. So you really need to know when to use such concentration. So usually the 50 is used below 2 years, and the 125 above 2 years, and the 250 usually in adolescent age group. So the orange one are inhaled steroid. Look at the one that below it. It's called dischaler. So there are inhaled steroid. The fluticasone can be given through dischaler. This is only inhaled steroid alone. The one below it is called turbohaler. turbohaler is this is a cover. This is a cover. If you remove the cover, um, it has it is like a piston. You have to screw. This is a screw, and you have to move the screw until you hear a click, and then you inhale. This is mainly given above 4 years, probably above 8 years, because it needs a certain technique and so on, because you have to hold your breath and so on, and this is only can be done above 5 years of age. So let's come to the second here, the long-acting bronchodilator, which is called the Serevant or the salmeterol. Salmeterol is the long-acting beta agonist, but it shouldn't be given alone. If it's given alone, this is a green color, but it's really prohibited now to use it alone. You have to use it with an inhaled steroid, a combination. So now everybody should use the combination therapy of beta agonist and the long-acting, uninhaled steroid, long-acting beta agonist and inhaled steroid for the moderate to severe asthma. And it has, again, the different grades of purple color. This one has the 25 and 50 microgram of inhaled steroid, and this one has the 125 and the 250 microgram of salmeterol and inhaled steroid. And if you come down, it can be given as a discaler, like the second one here below that one, or in a red turbohaler, and it's called Symbicort. A lot of adults, they prefer this one because it has beta agonist that can be used as a saver medication. That means every time you have a cough, you can use it. So it is used as a preventive medication, like an anti-inflammatory, but at the same time, it's like a saver medication that you can use it with a recurrent cough and so on. So a lot of people, they use the Symbicort these days. Again, different color. And as I mentioned, you will have, almost every year there is different medication, different color and so on. So you have to update yourself and you have to know how it is used, especially when you have your own center and so on. So again, there are so many in the market that you need to orient yourself about it. Again, we mentioned that there are small doses and you increase it up. They call it step-up medication. So there are guidelines that to show you when do you so this is called, for example, in mild asthma, you apply step 1, which is inhaled steroid, and short. For the step 2, like what it means that you probably have at least once a month an attack, low dose inhaled steroid, and another alternative, you can use the leukotriene, which is a singular leukotriene modifier. And of course the short-acting beta agonist or the Ventolin. If it becomes more severe, let's say twice a month, for example, so you go into step 3, which is low dose inhaled corticosteroid and long-acting beta agonist, plus the low dose, the leukotriene modifier. Or you can increase the dose of the inhaled steroid, and so on. So you step it up every time you don't see improvement, and then once the patient becomes stable, we call it step down. So usually you decrease the frequency, you decrease the dose, and you decrease the number of medication until you really stop the medication. Especially during the summertime, a lot of patients, they improve during summertime, whereas during winter time it may become. Now there are biological medication that is available. One of them is called Xolair or uh, I forgot what is the really the scientific name. Omalizumab, Xolair, that mainly we use it in this hospital above 5 or 6 years of age, and is according to the level of IgE. So it is an anti-IgE. It's called Xolair or omalizumab. And it is used a subcutaneous injection, usually either every 2 weeks or every 1 month for at least 6 months to 1 year or more than that, according to how bad is the asthma and how controlled it is. Now, there are many available biological agents, and some of them, like the dupilumab, which is also available. All these medications are available in our hospital, and it is mainly for interleukin 4 and interleukin 13. That's the main effect. Tralokinab, it is effective interleukin 13. Mepolizumab, which is also available in our hospital, is mainly it's effective in interleukin 5, and so on. So there are medication more or less the same cost as the Xolair, but we got used to Xolair for almost 10 years that we are using in these patients, especially when they have a high IgE. Preventive measure is very important. We mentioned most of them because you really can't prevent this excitatory process to these patients, and they will have less attacks. So it's the main tool here in treating this patient is the preventive measure by removing the triggers around them. It's very important to educate these parents. Sometimes you need to give them booklets about the triggers around the patients and so on. So please, it's very important when you counsel these patients, you have to talk about the triggers and how to prevent them. So a lot of, we could spend hours and hours in how to prevent these triggering factor. But it's very important to remove all these triggers around the patient, especially the smoke. So in conclusion, asthma represents the commonest chronic illness of childhood. A vast majority of asthmatic children can achieve optimum control by simple, basic intervention. Level of asthma control should replace severity in planning outpatient management. Patient education, action plan, environmental control represent important elements in asthma management. Several international and national guidelines are available to assist physicians in their practice. And you will see that, even around almost, let's say 3 to 5 years, they get together and put a new guideline. So you really have to update yourself regarding the new guidelines and the new discoveries in asthma management. Okay, thank you. I think we finished here. If you have any question.
Thank you so much, Doctora. Allah يعطيك العافية.
So
I don't think anyone would have any questions.
I think you are fed up from hearing about asthma, but trust me, when you become a physician, it's become difficult to control asthma. So it's easy to study, but it's not easy to practice. Anyway, good luck for all of you. Thank you very much.
Thank you, Doctor.
Thank you, Doctor.